Spinal Manipulation for the Prevention and Treatment of Non-Musculoskeletal Disorders, a Systematic Review. We know that somewhere between 3 to 10% of patients who receive care from chiropractors and osteopaths are treated for non-musculoskeletal disorders. Yet what is the evidence for this choice? Clearly, there are many different non-MSK disorders that are addressed, including asthma, infantile colic, dysmenorrhea, hypertension, and some might include migraine headache. There also has been a fair amount of research on the topic with mixed results. What happens, though, when you restrict that search to high-quality RCTs and review that evidence with the top chiropractic researchers from around the world? A new study has achieved this through a large collaboration of international researchers in this new publication, the Global Summit on the Efficacy and Effectiveness of Spinal Manipulative Therapy for the Prevention and Treatment of Non-MSK Disorders, a systematic review of the literature published in Chiropractic and Manual Therapies in 2021. In response to the conclusions of this review, there's likely going to be an outrage expressed by those who believe that chiropractic care is effective for non-MSK disorders. But let's start with the question that the researchers are not asking. Does chiropractic care affect individuals with non-MSK disorders? Note first that they don't refer to chiropractic care, but only to manipulation. So what are they asking? Researchers tend to narrow their clinical questions to a very specific comparison. They isolated spinal manipulation, mobilization, and traction alone. No combination care was allowed. They compared it to placebo, sham, and other interventions, and in some cases evaluated whether manipulation was effective in prevention or management as an adjunct approach, in other words, added to usual medical care. So who made up the research team? The Global Summit selected and invited participants who met one of the following criteria: a chiropractor with a PhD or a researcher with a PhD, not a chiropractor, with research expertise in chiropractic, actively involved in research defined as having published at least 5 peer-reviewed papers over the last 5 years, or appointed to an academic or educational institution. In addition, a small group of researchers who did not meet these criteria were invited to participate. There was also an attempt to make this review transparent, so the steering committee invited 28 representatives from 18 international, national, and provincial associations, regulators, 1 malpractice association, and 1 chiropractic college. They invited these organizations so that they could witness the scientific discussion and view firsthand the methods involved in conducting a systematic review. So which studies were included? Well, first, those that compared manipulation, mobilization, or traction to sham or placebo interventions to answer the following question: is spinal manipulation, spinal mobilization, or spinal traction efficacious for the prevention or management of non-musculoskeletal disorders? In other words, does it work in a research setting? And secondly, those that compared to other interventions, including sham intervention, when delivered in a pragmatic plan of management or no intervention, to answer a similar but different clinical question: is spinal manipulation, spinal mobilization, or spinal traction effective in the prevention or management of non-musculoskeletal disorders? In other words, does it work in a clinical setting, such as a standard practice setting? They did not include letters, editorials, commentaries, cadaveric or animal studies, conferences or government reports, books or book chapters, pilot or feasibility studies, and this is key: studies where spinal manipulation was included in a multimodal program of care were not included. As usual, there were quite a number of studies found with their search strategy. They found close to 5,000 studies, but through exclusion of duplicates and qualification based on review, they were left with only 16. They included studies on primary, secondary, or tertiary prevention. They found no RCTs related to primary prevention, in other words, preventing you from getting the disorder. But what is secondary and tertiary prevention? Well, secondary prevention is trying to detect a disease early on and prevent it from getting worse. And tertiary prevention is trying to improve quality of life and reduce the symptoms of a disease someone already has. 14 trials addressed secondary prevention, and 6 of the secondary prevention trials also included outcomes related to tertiary prevention. Of the 14 included RCTs, 3 were rated as high quality, 2 were deemed to be of acceptable quality, and 3 are of low quality, and 5 were rated as unacceptable quality. So for the high or acceptable quality studies, one study investigated diversified manipulation of T1 through T4 for the management of adults with hypertension. In the remaining 5, there was one study for each of the following: another hypertension study, infantile colic, primary dysmenorrhea, migraine, and asthma. None of the 6 RCTs of high or acceptable quality demonstrated that spinal manipulative therapy is efficacious or effective for the secondary or tertiary prevention of non-MSK disorders, and there were no studies on primary prevention. For the studies rated low or unacceptable, 2 of these were conducted in infants with colic, 2 in women with dysmenorrhea, 3 in adults with migraines, 1 in adults with hypertension, and 1 in adults with irritable bowel syndrome. They used 2 criteria to determine whether spinal manipulative therapy was efficacious or effective. First, statistical significance, meaning a study has to meet the usual p-value of less than 0.05, meaning the results were only 5% likely due to chance, and the same for the 95% confidence interval. But also, it had to be clinically significant, meaning it was enough of an improvement to be appreciated by a patient as improved. If neither was present in the study, they discussed the findings among the Global Summit participants and reached consensus on its clinical importance. They used 75% agreement as the threshold for consensus. The researchers remind us of why patients might improve with any treatment. The improvement is due to the natural course of the disease rather than the treatment. Contextual effects, such as the patient having expectations of the outcome, in other words, positive expectations of recovery, are associated with favorable health outcomes. The observed changes are due to other concurrent treatments, which is why they didn't include studies with multimodal care typical of a chiropractic practice. And also, it can be due to regression to the mean, which occurs when patients with more severe symptoms tend to show greater levels of improvement independently of the treatment they receive, due in part to the natural course of improvement over time. Let's be clear about what researchers mean when they say there is no evidence or evidence of clinical effect. And remember, this is different than saying there is evidence against. They refer to one of several things. No evidence or no evidence of clinical effect could be a situation where a placebo appears to be as effective as manipulation and then assumed to be an indicator that the real treatment is ineffective. Or studies may demonstrate statistical significance, results are not due to chance, but still not be clinically relevant, not a significant enough change to be meaningful for the patient. So here's an example of asthma. This study was included in their review, but the interpretation was based on 2 things: a comparison to a sham treatment and real manipulation, and both of these compared to usual medical care. What is being determined as clinically relevant or not is actually also 2 things. First, is there any objective improvement in spirometry? The answer is no, between and among the groups. And secondly, are there other outcomes that improve, such as quality of life, use of medication, or frequency of attacks? And the answer to that is actually yes. But because this is true for both the real and sham manipulation groups, it is then interpreted as no better than no treatment. So although there was an improvement in subjective indicators with real and sham over the usual medical care, because it isn't objective, in other words, measurable like spirometry, and because both real and sham showed only subjective improvement, it must not be real, or as the researchers conclude, not clinically relevant. Not sure the patients or the parents would agree. And another difference in approach. In this recent systematic review and meta-analysis on migraine and manipulation's effect on decreasing headache days, pain, and disability, the authors conclude, quote, spinal manipulation may be an effective therapeutic technique to reduce migraine days and pain intensity. However, given the limitations of studies indicated in this meta-analysis, we consider these results to be preliminary. Methodologically rigorous large-scale RCTs are warranted to better inform the evidence base for spinal manipulation as a treatment for migraine, unquote. And here we can see the forest plot for the meta-analysis that for both pain and disability, the effect size, although small to moderate, clearly indicates an advantage of manipulation over other treatment approaches on average. So from the perspective of the two review groups, it's simply different points of view. However, this conclusion is more supportive based on current evidence compared to the global summit conclusion. In fact, maybe the better way to start a sentence regarding research is on average, which leads us to some concepts. Practitioners who reject this systematic review would say, I see miracles in practice. Why aren't these studied or appear in research study results? Well, first of all, it depends on what you call or define as a miracle. Is it immediate relief after an adjustment in an acute patient, or immediate relief from a headache or asthma attack? Or is it gradual improvement in patients who have had no success with other providers? And then, how often do actual miracles occur in your practice? And are they the exceptions? Studies take the average or mean of the results, so patients that are in the extremes, the exceptions, are neutralized by averaging them in with everyone else. And here's an example. In a study on average, there was a decrease in pain of 25 points on a 100-point pain scale. That's the mean. Your patient's pain relief was 50. Studies often only include what is called a standard deviation, and often two standard deviations, to capture 95% of the data. Here it is. It's equal to 20 points. If two standard deviations were used to capture 95% of the results, your patient would be excluded with a cutoff of 45. Also, there's the question of when did they get better. If your patient had immediate relief, but the first measurement of pain was 2 weeks later, they're averaged in with everybody who improves at 2 weeks. Lost again. And of course, this review only evaluated research on manipulation, mobilization, or traction alone. Yet, with non-MSK disorders, chiropractors tend to use multimodal care, including nutritional advice or supplementation, physical therapy, exercise, etc. So this may not reflect, as a study, what you do as a practitioner. In summary, although many RCTs have been performed on non-musculoskeletal disorders and spinal manipulation, there are very few high-quality, low-bias studies. For those that are, there are only a handful of studies, sometimes only one study per condition, which means the weight of evidence is low in either direction, for or against. However, consistently in the high-quality studies, there was no statistical or clinical benefit over a comparison such as a sham treatment. However, in some studies, the placebo or sham worked as well as real manipulation, and sometimes even compared to usual medical management, but only in non-objective measures such as quality of life, reduction in medication use, etc. So now we know that the researchers are correct in their interpretation, but there can be two truths that seem diametrically opposed, and that is that they are correct about manipulation, mobilization, or traction only, but do not address multimodal care as carried out in most clinical settings. Secondly, they are correct when comparing to placebo or sham. However, when placebo or sham is better than either natural history or another treatment, the patient still benefits. Scientifically, it's then deemed non-significant, but clinically there might be value in determining the common element between real and sham and incorporate that into the application to the patient, or simply tell the patient that sham works just as well and let them decide, as Kabchuk did in his now famous placebo study, where patients were fully aware they were taking a placebo pill but still responded. Hopefully, this clarifies the scientific approach used in this study, and that it addresses a very specific clinical question, but does not yet directly answer the question of multimodal chiropractic approach to non-musculoskeletal disorders.